I want to welcome everybody, and I'm Elizabeth Sullivan. I'm ASPP president, and on behalf of our entire leadership team, Danielle Eisenberg, Rakefet Gruberg, Megan Nolan, Dustin Cahood, we'd like to welcome you to today's edition of our virtual Meet the Author series. As you all know, today's author is Dr. Beth Feldman, and she will be in conversation with Dr. Danielle Knafo. Dr. Feldman has written both a vulnerable and accessible book, which describes her clinical work with 9 patients. I was impressed by her honesty in writing not just about her successes with these patients, but also her regrets and how her own history intersects with her clinical work. I hope that if you have not yet read Case Studies in Relational Psychotherapy and Psychoanalysis, If I Could Turn Back Time, this presentation will encourage you to read it. The seminar will run for an hour and a half. Dr. Feldman and Dr. Knafo will converse for the first 45 minutes, and then we will open the floor to the participants. Please hold your comments and questions until this time, but feel free to write in the chat box at any point. Today's event is not HIPAA compliant, and we are recording it. We plan to post an edited YouTube video on our channel in a few weeks. Please keep this in mind, and if you feel compelled to bring up any case material during our discussion, please keep it brief, relevant, and extremely de-identified. Safeguarding the confidentiality of clinical material is the cornerstone of our clinical practice. If you would like CE credits, you must be present for 90 minutes, which will be monitored. We'd also appreciate it if you would all turn your camera on too. It's easier to talk to faces than names. The evaluation will be emailed to you in the next day or so, only if you have met the 90-minute time requirement. Please fill it out and return it within 3 days, and your CE certificate will be emailed to you within a few weeks. I'd like to thank the Director of the Postgraduate Programs, Dr. Amira Simha Alpern, for joining us today and for her continual support of ASPP. Please visit our website, www.adelphiaspp.org, for more information about our society and our events. I'd now like to turn it over to Dr. Dustin Cahood, who is the chairperson of all our Meet the Author events. Dr. Cahood will introduce today's speakers and facilitate the Q&A. Dustin?
Thanks so much, Elizabeth. I'm really delighted to now introduce Danielle Knafo. Danielle is a prolific author who's written extensively on the topics of art and creativity, psychoanalysis, trauma, and psychosis, and most recently, technology and AI. She's worked psychoanalytically for over 40 years and maintains a private practice in Manhattan and Great Neck. On a personal note, Danielle was my professor and mentor in the doctoral program at LIU Post. During her tenure there, she inspired so many students to pursue psychoanalytic training, myself included. She currently teaches at the Adelphi Postgraduate Program and NYU's postdoc program for psychoanalysis and psychotherapy. And she's helped a lot of students who still today have really come to understand what psychoanalysis is about for the first time through her class, and remembers her class as being the start of that inspiration. So she really kept the spirit of psychoanalysis alive at LIU Post and will never be forgotten for that by her students. I also had the privilege of being a part of Danielle's writing group with Beth Feldman, the author of today's Meet the Author. And so I had an insider's experience of the whole process of the book and reading various drafts as she was beginning. And it's really exciting to see how it all came together today. For her book, and to be able to talk about it today with Danielle and Beth. So thank you so much. Really looking forward to this. Without further ado, I'm going to now turn it over to Danielle Knafo.
Okay. Thank you, Dustin. Thank you, Elizabeth. Thank you, everybody, ASPP. We were talking before that this is my fourth Meet the Author, either as an author or as a moderator. So I'm a regular here, and I'm happy to be so because I love writing, and I love to write, and I love to help other people write. And So let me introduce Beth. Beth, first of all, the facts. She's a clinical psychologist. She's a relational psychoanalyst. She has a private practice in Plainview, Long Island. She treats adults and adolescents, individuals, couples, and group therapy. She is also the co-host of a podcast, Being a Parent is Hard. And she's now an adjunct faculty member at the postgraduate program here in psychotherapy and psychoanalysis at Derner. I think she teaches a course on self-psychology. Um, she has two adult children. She lives with her husband. She is an adamant dog lover. In our group, the dogs are there with us. um, so let me say something about, how a little bit personal, something personal about my relationship with Beth. Beth has been, we were trying before this meetings began, I was trying to remember how long I've been running this writing group, because Beth came to my writing group in Manhattan when it began, and it was in person. And then when COVID hit, kind of everything stopped, including the group. But then I restarted it during COVID on Zoom, and Beth rejoined. And I just want to say that I've always been struck right from the beginning with Beth's raw talent in writing. She's a wonderful storyteller, and she really gets into the phenomenology of psychotherapy. She brings us into the room with her. She brings her patients to life. And at first, the biggest challenge with Beth was that she hated theory. And she just wanted to tell the story. And I thought, if you're writing psychoanalytically, let's weave in a little theory here and there. Reluctantly, over time, she developed an interest in theory as well, especially self-psychology and relational theories. And you can see that in the final versions of the chapters in this book. She wrote one clinical tale after another, and she took on some of her most challenging cases. She made me think of Freud, who wrote up the Dora case because he felt there was some unfinished business there. She writes about the cases that stay in our minds, the ones where we have unfinished business, the ones that challenge us, the ones that have relational intensity, that pull us in, that stay with us long after the case is closed. Um, she shows us that just because we no longer see a patient, it doesn't mean that the case is closed. If there's such a thing as a closed case, I don't think there is. So over the years, the group read one case after another and versions of the cases that Beth brought to the group. And after a while, I said, you know what? This looks like a book to me. And and I encouraged Beth to begin seeing this as a book, not just as, separate cases. And I'm so happy that, to see how it finally uh, did come together as a book. But it wasn't enough to stop there, that she had this collection of cases. There are other books that present collections of cases, and she wanted to have a unique angle to the book. And she had a few ideas, but the best idea was the one she landed on, and that was with the help of Cher, If I Could Turn Back Time. All of you know the song. It's a great song, very catchy. And it was a brilliant idea. We all in the group loved it. And it's an idea that hadn't been done before. It's an idea that's wonderful, that shows a vulnerability on the part of the therapist to look back at one's cases, to ask what we could have done differently, better. What did we miss? not just tie up case stories in a nice little bow, but to really go back and analyze it with hindsight, right? Um, what if we had a second chance? So, so I think it was just a great angle to have, and it's what gives this book its own unique uh, on psychoanalytic therapy. So, without further ado, I asked Beth in advance to give me some questions she would want like me to ask her today. And she said, "You just do it. You do you." And I'll do me. And I love that she trusted me enough and feels confident enough in what she's written that we can just do this. So whatever you're hearing is completely spontaneous. Um, I wrote out a few questions, but she has not heard these questions before. So, my first question to you, Beth, is can you tell us a little bit about the first case that you decided to write about and why?
Sure. Hi everybody. Thank you so much for coming and thank you to ASPP for having me. This is really thrilling for me. Um, Look, I think the first case was probably chapter one, and it was the patient who wound up taking her own life. And I had so many mixed feelings. And I feel a little badly saying mixed feelings because the next question that comes to my mind is, well, how could they be mixed? It's just horrible. Um, but I felt like this person had such a long life and had so much pain, and it was so unremitting, and had wanted this sense of relief for so long. And I couldn't figure out really what she had been waiting for. And she had a kind of uniquely devastating sense of isolation and loneliness. You know, she would get through the holidays by just, taking sleeping pills. It was the only way to get through Christmas, for example. Um, and I had this very strong feeling that it was, how do you leave if nobody's going to miss you? If nobody's going to notice you're gone. And I had this very strong feeling that if nothing else, the relationship gave her that. So it was a very, very upsetting, emotional.
You're mute, Beth.
Oh,
Unmute yourself.
Can you hear me?
Yeah. Go
At
back on what
first,
you just said.
I didn't touch anything. It was an incredibly painful experience that I never want to have again. Um, and one that I learned a lot from, but one that so many feelings were just reverberating through me. And so writing about it help me to manage it and understand it better. And I think it's such an important topic to talk about too.
Okay. And that's why we all thought that should be chapter one. Um, I don't know. This might coincide with that answer. What was the most difficult case for you to write about?
Mm. I think the most difficult case would be chapter 5, What's That Smell? Because that's a chapter about a woman who was relentlessly hostile and aggressive and incredibly difficult. Um, and really kind of staying alive and staying attuned. Each session was a challenge. And I wanted the therapy to end every 10 seconds. And yet I didn't want it to end. I wanted to hang in there and find a way to reach her. So I had such ambivalent feelings about our work together. And the fact that I felt so frustrated in being unable to find a way to connect with her and to make her a little bit less hostile, to help her find a way to take some of what I wanted to offer and not just kind of spit it back at me. So I think that was probably the hardest one. that too didn't have a happy ending.
That's the thing that I love about Beth's courage and to be vulnerable in her telling of the cases and even in talking with us that we have to do the kind of work we do, we have to be vulnerable. And, and just because we're vulnerable in the room doesn't mean we're going to be vulnerable on paper, which takes vulnerability plus courage, which Beth has. So, what have you learned the most about what psychoanalytic treatment can and cannot do from writing up these cases and looking back and also seeing maybe missteps or ruptures or whatever? What give us that? This is a big question.
Huge question.
Huge. Take whatever part of it you want.
I'm a true believer. I am absolutely a true believer. I think psychotherapy and psychoanalysis can change lives, change the therapist's life, change the patient's life, for sure. Um, the patient doesn't have to meet you halfway. People say when they want a loved one to come into therapy, I do a lot of work with substance abusers, for example, they have to be ready, they have to want to come. And I say no, they just have to come.
Mhm.
It's part of my job to help them get ready, to help them want more. Um, but there does have to be the showing up part of it. They do have to show up, and they do have to show up for a chunk of time so that we can get a little bit of traction, build the relationship, and see where we can go with it. So it can do a tremendous amount. It can't do everything, and it certainly can't do it single-handedly. I've been lucky enough to work with a lot of men and women who just work so hard, and I know how painful it is for them. And they kind of are relentless in their wish to make things better.
And some succeed and some don't, right? Is that what you're saying?
Well, some succeed and some don't. And, everything is, what minute and time are you talking about? Some treatments end, but the work continues. And sometimes you're lucky enough to hear from that patient down the road. Sometimes you're not. Sometimes you hear about them that they're doing well. Sometimes you just sit back and think about somebody and hope that they're doing well. Um, so sometimes you see it in the moment, sometimes you don't, sometimes it's not helpful. There certainly are times and instances where it wasn't helpful, and okay, you just have to be able to recognize that. And again, I always want to look and say to myself, what could I have done differently? Maybe nothing, but maybe something. Maybe it would have made a
Well,
difference.
you do
Maybe it
come
wouldn't
up
have.
with things for each one of your cases. Maybe you can give your audience here an example of one of the times where you looked back and you realized, I could have done something different here. Maybe pick one.
Sure. So chapter, maybe it's 8. I think the boy with the beautiful smile. Um, Josh and I just had this wonderful relationship. I remember meeting his parents first, and his father, he wasn't in the room yet. He was 15 at the time. His father asked me a million questions, and his mom just sat quietly. And finally, I said to her, do you have any questions? And she said, nope, you're a member of the tribe. He'll talk to you. And I thought to myself, is it being Jewish? That I am, they are. I said, what do you mean? And she said, you're a dog person. Because she saw, I don't know if you could see the pictures behind me. Um, and true enough, he was a huge dog person. She had 4, he had 2. Um, and we developed this incredibly close relationship with this kind of synchronicity between us. And there came a time over the course of an 11-year treatment where things spiraled out of control and I had no idea it was coming. There was this big kind of crash and paralysis, and it had pretty significant implications for him academically. And looking back, I loved being this idealized therapist. I loved the way that Josh saw me, and he loved, you know, the way that I saw him, kind of basking in my appreciation of him. And it led us to really not talk about anger, to dissociate the conflicts, to not dive deeper. Even when he started missing sessions at a certain point, then I became kind of annoyingly parental, and I had this like very irritating cheerleading thing going on. Come on, Josh, you can do it. And looking back, that was, not particularly useful. So there were things like that for sure that had I talked more about my anger at his disappearing acts, had I encouraged him more to express his anger, then he wouldn't have had to be my protector. He would have seen that if there was a rupture in our relationship, we could talk about it and we could work through it. And he could have gotten in touch with these parts of himself that are bold and strong and important parts of himself. Just because they're not sweet doesn't make them any less valuable.
Right. That's a great example of how we can collude. Our defenses can collude with the patient's defenses to keep things
Absolutely.
a certain way and not really analyze them. That's a great example. So that leads me to a question about what did you learn most about yourself in writing this book? Beth brings herself into the cases. These are not just cases that are other oriented and focused just on the patient. We're very aware of what happens in the therapist and in the therapist's mind and the therapist's emotional life. And so, what can you say from writing this book that you learned the most about yourself? You can be as personal as you want.
I'm glad I didn't know that question ahead of time. Um, a very close friend of mine said to me after reading the book, "You're much more open in the book than you are in real life."
Mm,
And so everything I wrote that was personal, I kept like having this mantra to myself, like, you can take it out, you can erase it, you can hit the delete button. Um, and so part of what I realized is how uncomfortable I am sharing certain personal things. But I felt like it was just incredibly important. I wanted people to be in the room with me, and I wanted it to be honest.
mhm.
Um, I think that's the other thing I learned is how important honesty is to me, um, emotional honesty. So both of those things that I'm more uncomfortable than I thought I would be with the vulnerability, but it's super important to me.
Yeah, I think that's one of the things I learned the most about you from your writing is just how honest you could be. And sometimes in the group, people ask, "Are you sure you want to say this? Are you sure you want to put this out there?" Um, because we're not used to, often in analytic writing, we focus so much on the patient and with the relational term, there certainly has been more focus on the analyst, but Beth is right in there with the patient, what's happening there and what's happening in her, and if not at the time, in retrospect, right? Um, so what do you have a group of potential readers here? What do you want your readers to know or learn about from reading your book about therapy, about psychoanalysis?
I assume people are curious about the things that I'm curious about. Maybe not, but I'm curious about what goes on in other people's offices. I'm curious about what goes on I am fortunate enough to be in this wonderful peer supervision group. I'm curious about what it's like to be a patient in each of their offices and what exactly goes on. Um, so if you're curious, I wrote it for lay people and for people in the field, for people who are interested in what happens in therapy, how it can be so beneficial, how it can go awry. So if you're interested in a bird's eye view, one version of the book was called Behind Closed Doors. If you're interested in what goes on behind closed doors in one particular office, it will give you that. I find the whole thing fascinating. I find the twists and turns of the therapeutic relationship and the course of psychotherapy in each case really fascinating.
So one of the things I think this book, like Beth says, it's written in a way it doesn't have a lot of jargon at all, um, almost none. So that's why it's so real and so easy to read. It's a page turner. Um, and I thought that, it's easy to read for anyone, people in the field, people not in the field, but I thought particularly for early career therapists. It's a wonderful way to get in there, learn about, the dynamics, the interpersonal dynamics, what goes on. She normalizes so many of the feelings that a therapist has that an early career therapist might be ashamed of. The vulnerability, the insecurities, the questioning oneself, all of those things that happen to all of us all the time, but she writes it, she says it when it happens. Um, so I'm wondering if you could say a few words about the advice you might give to new therapists.
What came to my mind as you were talking is, in the intro, when I got through the theory part, which was a challenge for me, um, I talked about the fact that in another life, I used to play competitive tennis. And the one thing I learned when a match got close is you can't play scared. And I feel that way in therapy. And I feel that's what I would say to new therapists is don't be scared. Be you, be there, be real. And you're going to make mistakes. But if you're not emotional and you're not authentic, you're not going to move the emotional mountains. That when you work from the safety of your analytic perch, it's just not the same. It's not the same experience for you or the patient. So I would say dive in, worry less, and talk to supervisors, talk to friends.
And I would add, learn from the mistakes.
Yeah.
Don't beat yourself up, just keep learning from it, keep growing from it. Um, since this is a book of cases, real cases, I'm sure some of you are wondering what how Beth handled the issue of consent, permission, asking permission, disguising case. Can you address that, all three of those somehow? Because whenever we write up cases, we have to consider these things.
Sure. Um, 4 of the cases I got consent from and sent the people a copy of the chapter. And the rest, there's one that is kind of a composite of 2 cases. And the other few, just so many of the details were changed so that there's no way that it's identifiable in any universe. But to me, the essence of everything stayed the same. That was what was important, that the essence of the emotions and the conflicts and the quality of the relationship stayed the same.
Yeah, yeah. And you brought that to the group a lot of times, right? Is this enough of a disguise? Or if this is where it's good to get other eyes and ears, because you might think something is a disguise and somebody else might say, wait a minute, but what about this? Or what about this? And sometimes you don't want to disguise so much that it takes it so far from who the person is. So it's a very, very tricky fine line. Um, of dealing with it. But that was part of what Beth dealt with chapter by chapter.
I also spoke with an attorney from my liability company and went over each case and made sure from his perspective that there was enough
Yeah.
changing anything that could have been identifying.
So I want you to be in the mentor role for a minute. And I'm sure that, everybody here, almost everybody here is a therapist, analyst, either active or in the past. But let's say somebody wants to write up a case, one of their cases. Um, how would you advise them where to begin, how to choose what to include, how much of yourself to include? Like give a little mentorship advice to people who are thinking now as we speak, hey, I have some cases I would like to write up. How do you begin?
I think you begin by opening your computer and just maybe you pour a glass of wine, maybe you pull up a dog or two or three, and just starting to write and recognize that it's not permanent, you know. You write and you write and you write and then you like look at it the next day. Um, I think there's a fear of getting started that once one overcomes, and a lot of times I would start writing and it wouldn't be what I wound up with, but it would be kind of the path that got me there.
Mhm.
So I think and I think it's easiest to start with an interaction with a patient. You know, rather I originally started with identifying data, right? So and so is a 35-year-old married, blah blah blah.
Yes. Yeah.
And I think, you used to say like bring it to life more.
I
So
would tell her this isn't an intake, you know.
so I would go to a like, feisty interaction or an
Hmm.
emotional interaction and write that first and grab the reader's attention and then go back and get into more who this person is and where they come from and etc. Um, so that's what I would suggest is to just nobody has to see it. You can always delete it. Just start writing and start with something that wakes you up.
How about the question of how much of yourself to include?
I think that's an acquired taste.
Say
It,
more. Say more.
it took me a while to, put these things in. I'm glad I did. I had somebody in my office a few weeks ago, a woman who's had some bad anxiety of late and a lot of shame around that. And she said, "Oh my God, I read your book." I said, "Dr. Feldman had panic attacks. I don't feel so badly." And I felt so good that
Yeah.
that was able to help her.
Yeah.
Um, Look, I think you have to be able to talk. You should talk about things that you're in a place where you're comfortable talking about it. Obviously, there are things we don't talk about. There are boundaries you want to keep up for sure. Um, but like I said, what you write and what you keep in the written product are different things. So
Yes.
sometimes it's good to write and then you say, I don't think so. And you take it out. And that's okay. You've kind of verbalized it. You've put it out there and you decided that it doesn't belong, or at least not yet.
Yes, exactly. Get rid of censorship when you're writing, at least in the beginning.
Right.
Writing is different from editing. You write, I always encourage people write wherever you go, begin wherever you begin, but don't censor. The censorship can come after when you're using, you know.
The other thing I would suggest that I do when you're starting to write is I'll get ideas like I'll be on the spin bike or I'll be in the shower and I just like write in my phone in the notes section, just a few words to know to go back to it. So whenever an idea comes to you, just jot it down. Doesn't matter what it has to do with.
Right. You're writing all the time. Once you decide you're writing something, you're writing all the time. And so it's in your mind. And so you should have somewhere to jot down notes when you get them, because they're fleeting. They can be fleeting. Uh, but it's exciting because it's a part of you now that your unconscious is already mulling around. Um, okay. What about any cases you chose not to include? You were talking about right, and then, you can throw things out. What were the things? Tell us the things you threw out or that you decided not to include and why.
I didn't throw it out. I took
Right.
it out because unfortunately, I couldn't find a way to make it belong. But originally, there was a chapter called Welcome to the Asylum, and it
Mm,
was about my inpatient work.
right.
And it had, I think, 5 little vignettes within the chapter. And they were so important to my development as a clinician that I really wanted to keep them in, but it didn't fit the rest of the book. So I had to take it out. So, in that way, I
But you
wanted to
still
keep it in,
have
but
it.
it didn't fit.
You still have it. It might fit somewhere else. Once you're writing, you find other ways, either to write or to present what you've done. Um, I want you to say, because of this angle that you took in this book, which is a very unique and very important angle, there's a lot of research done on ruptures and repairs. That's what one of the psychoanalysts are not big researchers, but you have, attachment research, early parental research, ruptures and repairs happens to be one of the big areas of research. Um, but Beth got into it without necessarily looking so much at the research. It was really from her and thinking about the cases and looking back. So, and yet this is such an important piece of what she adds to each case. She gives you the case and then at the end tells you, I could turn back time. What would I do? So I want you to really talk about that part and what you do in that part, um, what you look at, what you find. Tell us more about that part of the book.
The if I could turn back time part,
Yeah, yeah.
of course, that's my favorite part. I think it's the most valuable part. I really enjoyed writing that part. Um, it really looks at sometimes in most chapters, I think I write what I surely wouldn't do differently, right? There's one patient that I gave a birthday present to. And of course, I was acting out of my need to be this like nurturing mother and whatever, I wouldn't do it any differently. But there was a lot in that case that I would do differently. One of the things as I looked back over the different sections, if I could turn back time sections, is that, I'm not great with anger. As I mentioned in the book, I got yelled at a decent amount as a kid. I didn't like being the recipient of anger, and I try very hard not to yell as an adult. So, um, encouraging my patients to get angry with me and to voice their anger and share their anger has been something that I've learned over time. And I think it's exceptionally important. Um, and as I look at a lot of the versions of the if I could turn back time, it would be to encourage when things are going well, to encourage the person to explore some of their less positive feelings and some of their disappointments, or it doesn't have to be things that they're enraged about, but things that aren't sitting well with them, or, missteps that I'm making. So I think that's one of the things I found a lot, that I didn't encourage it enough. With the first patient, the one who killed herself, it was a 10-month treatment. And she was so fragile that I said to myself, soon, like there was a lot of envy, there was a lot of rage. I didn't feel she was ready. I felt like if I brought it up and asked her to talk about it with me, it might be a rupture that she couldn't tolerate. and we were early in our work together. So I didn't know there were like moments left on our clock. Um, so of course, if I could turn back time, I would be bolder. I would say, listen, Claire, I'm very concerned about saying this to you because we don't know each other that well, but, and then I would, ask her whatever I wanted to ask her. Um, so those are the kinds of things that I look at. What I'm not even going to say sometimes it's where I went wrong for sure. Sometimes it's where I chose to go and it didn't work out great. So in hindsight, I'd go left instead of right.
Or you even wonder. Sometimes you're just wondering what might have happened had I done this or said this instead. Yeah.
And sometimes there are things that I simply didn't explore, right? With in A Better Man with Brian. We talk so much about how abusive and brutal his father was. We never talked about the fact that his mother stayed with his father for as long as she did, and that she never really, despite being a wonderful, loving mother, never really prioritized her son's safety and getting him away from this brutal figure, even though he didn't brutalize Brian, he brutalized her. But it was horrific for Brian to witness it and terrible for him in every way. I never went there. I didn't see it. And so it wasn't until I was looking back that I think somebody pointed it out in the writing group, as a matter of fact. Hey, you never talked about X. And it was like, you're right, I didn't.
The blind spots that
Hmm.
we all have and recognizing them so much easier afterwards. Um, you know, Beth said this is the favorite part of the book, writing the if I could it was such a favorite of hers that she got carried away with it, you know, and I would have to remind her, you also did good, just like, and I could have done this, and I could have done that. So it got more balanced.
I just want to say something to that. That people have said to me that I was very self-critical. And I didn't feel like I was being self-critical. Like, we can only do what we can do. We can only see what we can see. I'm just looking back and saying, hey, what could have been different?
Yes, yes.
Sometimes I was self-critical, but the lion's share of it was looking back. What can I learn from it? And what can I help other people learn from it?
And the main thing I think you can help people learn from is to look and look back. Just because if somebody leaves precipitously, to not just say, okay, goodbye, that didn't work, but to really, go over the case. And whether you write about it, writing about a case is a wonderful way to really go over it and understand it anew. And then things will pop out, things will pop out at you about the case. So your honesty, your courage, your authenticity all come through very strongly throughout the book. Um, and I recommend it to all of those who haven't read it. Those are my questions for now, unless something else comes up in the discussion. But maybe we should open it up to the audience. I'm sure people will have some thoughts or questions for Beth or myself, really.
And you could either raise your hand, you can use the raise hand icon if you have a question, or you could write it in the chat box. Or, but I would just encourage people to raise their hand if they can. Um,
Alan.
and then we can unmute you.
Okay, great. So I had the privilege of reading this book in 15-page increments because I'm a member of the writing group, and Danielle puts a limit. You're only allowed to present 15 pages so as not to overwhelm one another. Uh, the very first 15, my very first exposure to the group was I got these 15 pages from Beth. It's included in the book. It was just the personal experience of she's hitting balls, tennis balls against a wall, as I've done so many times, and imagining that she's at Wimbledon as she's a late, uh, uh, 10 or 11, I think. Um, and a guy pulls up in a van and he wants to expose himself to her, and she backs off, and then he threatens to kill her if she doesn't get lost. And she runs all the way home, and she never tells anybody, which she didn't. I don't think she mentions in the book. She never speaks a word of this to her parents at the time. And I said to my wife, I'm in this writing group, and Elizabeth Strout is in the group because it really reminded me of the contemporary, maybe not so contemporary anymore, but the novelist who really thrives on surprise, and that element of surprise in the book, it really got to me right away, and and she continues to surprise. And then the experience of reading the whole thing of a piece uh, was even more powerful to me. And I wished I'd had it early in my career rather than after I've retired from clinical practice. But I'm still glad to have it. Uh, a couple of questions I have. One is, uh, Beth, you identify yourself as relational. You're certainly very self-psychological. Just how did you come to, you know, to call yourself a relational psychoanalyst as opposed to a self-psychologist?
Mm.
First, let me respond to that vignette that you just gave. It is included. It's in an unspoken promise, and it's included in the context of this is a patient who 14-year-old patient who wouldn't speak more than 2 or 3 words each session. And at one point, I was just getting so fed up. The sessions took forever and a day. And I was getting irritated. And all of a sudden, this memory pops into my mind. And I write that I ran home, I was out of breath and I was out of tears, and I didn't speak of it for 15 years. And as soon as I remembered that, my empathy returned, my patience returned, that there are some things that you can't put words to. You're not ready to put words to, words don't begin to cover it. So it really helped me work with Mandy. It just kind of washed over me all of a sudden. So I am relationally trained. I went to a relational institute. I used to drive to class with a friend of mine who was more interpersonal. And I would talk about like a 1.5 person psychology, and she would talk about a 2 person psychology, and we would disagree all the time. I think now there's relational self-psychology, which kind of suits me best, I think. But there are plenty of times when I very much deal with the relationship and deal from the other position, not just from the within, the person's experience position. So part of my issue with theory is I don't like being told what to do, and I don't like to feel like I have to pigeonhole myself. So the relational umbrella is a broad enough umbrella, but I do find myself always gravitating towards self-psychology and the importance of empathy.
If I may ask one other question. The chapter where you were writing about the treatment, it's late. It's one of the late chapters, maybe second to last. where you write about a treatment you were conducting while your father was dying of COVID. A very moving chapter. Um, I assume that therapy was conducted via Zoom. Is that right? So,
Yes.
you talked about not disclosing your grief to any of your patients at that time. And I wonder if you could turn back time and speculate about how that might have been different had it not been over Zoom. The thrust of my question is that I had found my last 2 years of practice were entirely over Zoom, and I found it a little bit easier to hide out.
Hmm.
You know, that people didn't fully experience like what was going on with me, and I'm sure I did not fully experience what was going on with them in the same way had I been in the room. So I wondered uh, if you think it might have been different for you.
Yeah, unfortunately, I had the experience of losing my father during the height of the pandemic and then losing my mom a few years later. And, and I did take some time off with her, not a lot, but there one could be with other people then. One could go to a friend's house, have people over, have an in-person shiva. There was a way to mourn and not just kind of. I wasn't by myself. I was with my husband and kids, but I think what he disappeared. I think that if it were a regular time, I probably would have taken more time off. I don't know that I would have disclosed more. I'm not sure about that. You know, I like to feel, I think like all of us, a little bit more in control of things before I talk about them.
Sure. Thank you, and congratulations on a wonderful book.
Thank you, and thank you for your help.
Other questions, comments? Marty?
Hi. First of all, thank you for a wonderful presentation. I admit I have not read the book yet, but I plan to. But I also wanted to ask you, what would you say is the most lasting impact on you as a person, and then as a therapist? Um, the impact of having written this book.
That's a great question.
Thank you.
None of mine were great. Just kidding.
Hi, Danielle.
Um, I'll just say the first thing that comes to my mind. The first thing that comes to my mind is I have gotten so much incredible support from people. And that has really tremendously moved me as a person. Um, I can't begin to tell you how grateful I am for the kind of interest and support that I've gotten from so many people. I mean, it's one thing when I get good feedback in a writing group. It's another thing when I text Danielle 17 times, a million questions, and within 5 seconds, 5 minutes, I get a response every single time. That kind of support makes you feel like you're just not in it alone.
And it tells
So
you I don't have a life.
that's not what it told me. Um, as a clinician, it told me that we will never be replaced by AI because it is our humanness. It's our real, the the longing to heal, the wish to connect, the willingness to kind of mess up and figure it out together, that's what makes therapy work. That's what makes it invaluable. That's I think for me the secret is, to be yourself and put yourself in there. The focus is always on the patient, but you're present and you're giving it your all, and I think that that's invaluable.
Thank you. I was thinking that it was along those lines, but to be so specific is to say, in opening yourself via the book, you opened yourself to receive so much.
Well said, yes.
Yeah. Thank you.
Thank you.
Elizabeth.
Hi, Beth. Am I correct in saying that in one of the chapters you talk about a patient who comes back into treatment? I'm just
Yes.
looking through the book and I can't find it right now. But so my question is, was that one of the patients that you told that you were writing this book about? And if so, did the book come into, has the book come into the treatment? Or what you wrote or your regrets or your, what you would have done if you could change, has that come into the treatment? And did they read the chapter?
Yes, yes, and yes. This is one of my favorite stories. This was the Heartbreak Kid. And this was a patient who was a 20-year-old opiate addict. We worked together for about 4 years. It was kind of one disaster after another. She wound up in rehab and then in the hospital and then in jail, and it just kind of everything blew up. And we lost touch. Her mom pulled her out of treatment, threw her in rehab, etc. I couldn't get in touch with them. A few years went by, and I was going into a deli, and the woman at the counter looked like a healthier, wasn't this person, but it looked like a healthier version of this person. And I thought to myself, like, she may be dead, she may be in jail. This isn't her, but it looks so much like what she would look like if she were sober. And I went up to the counter and she breaks into the biggest smile and says, "Dr. Feldman, do you recognize me?" And it was her. And I was utterly shocked. And so we sat down and she filled me in on what had happened. And, maybe like a few months later, I got a phone call from her. She wanted to come back into treatment and is still sober and still doing beautifully. So we do talk about the book and we talk about just how far she's come and how, amazing she's done.
Does she have any feelings about the regrets that you write about in the book in the If I Could Turn Back Time section?
None that she shared with me, but, in keeping with what I said before, maybe I should probe more.
Mira.
Hi, thank you, Beth, for this beautiful, honest, articulate presentation of the book. I have two questions, if I may ask. One is that many clinicians are reluctant either to get consent from the parents, the patients, look what I'm saying, or to involve the patient in a writing in any manner. I'm just wondering, what was your experience of sharing the books? I'm sorry, the chapters with each of the patients. If you can share with us a little bit, what was the reaction and how did it change, if at all, the course of therapy after that?
Well, I think the reactions were very positive, but of course, I'm only getting consent from the people who things went well with. So it was, the reactions were very positive. I think people felt good that they meant enough to me and that our work stayed alive with me, and that I wanted to write about them. So it really was positive. When God, one of my favorite chapters, Forever in a Moment, Nikki made sure to tell me that I got the name of the children's book wrong that I included in there, and made a few little things like that, which was great. Just changed that, but substantively, everybody seemed to feel really good about it. I think it let them see how important they were to me, and that was important for me too, that they saw that.
Did it change the therapy in any way? Did it add, or did it whatever? Did it mean anything in the therapy subsequent to their reading the chapter?
I don't think so. Or let me put it differently, not that I've seen yet. It hasn't, did it strengthen the bond? Maybe. There are two people who I'm still working with, so some of them have ended treatment and had ended a while ago. So I think, in those cases, it's yet to be determined.
You had a second question, Amira?
If I may ask, and I just don't want to take over. I have the privilege of knowing Beth before, and I know her staunch resistance to theory. That's a really staunch resistance. Why do I need her? And I'm wondering, Beth, you had a beautiful, and I did share it with you, you have a beautiful theoretical introduction. You're summarizing the theory in such a personal manner and make it your own in a way that I rarely see. So you did very profound and articulate theory, but you really made it yours. So I'm not going to ask you what the resistance was about, because this is not your therapy. But what I'm going to ask you is, how did you find, once you agreed to kind of incorporate and anchor it within your cases you intuitively, you're an excellent therapist. So whatever the theory said, you did. It's not that you're, so I think in some way in your unconscious, the theory existed. I don't think you were completely theory-less, and I don't think you put the roadmap outside the room somehow. But my question is, what did it do to you as a clinician, as a writer, afterwards when you finally agreed to incorporate the theory, and what did it make any difference for you? Did it show that the case is in a different manner or whatever?
Well, first of all, it wasn't just that I kind of came around to that way of thinking. I actually got this very wonderful publisher from Routledge to read my collection of case stories, and she said, I love it, but I won't publish it unless you have theory and a theme. So that was kind of, I had a choice to make at that point. Look, once I wrapped myself around it and started doing it, it isn't that I didn't like reading theory. I didn't like writing about theory, in part because I don't like jargon. And so I tried to write about it using as few 3 or 4 syllable words as possible. Did it change the way that I see things in the room? Like, wow, I actually do that? Not so much. I had an awareness of what I was doing and where I was pulling it from. It was more just a resistance that when it came to writing, I love telling stories. I love writing stories. Writing and getting references and all the kind of hard wiring of writing theory just didn't come naturally to me. So I required a bit of prodding.
Somebody that you didn't like to do that, you did an excellent job. No, but you did excellent, period, even. But to think that how much you didn't want it, it's just amazing how you kind of was able to pull it in such a personal manner. It was beautiful to read it.
Well, Danielle gets some credit for that because she kept saying, make it your own. You don't have to spit it back out. Make it your own. So that was my guidance.
You did.
Thank you.
Gary?
first of all, I want to thank you both. It was fabulous conversation that you had. I loved your questions, Danielle, and I loved your answers, Beth. I have a question. Have you ever collaborated with a patient to write up a case?
I have not. This was my first book, so I've had some thoughts about it, but I'm concerned that that might cause some ripples in the relationship and in the therapy. So I'm kind of hesitant to do that.
I've done it. I've
Uh,
done it a couple of times. The idea didn't come from me necessarily. It was again in requesting consent from a patient. I write a lot, as some of you know, and I write up cases a lot. I always ask for consent. I share what I write with a patient. I let them change or, comment on anything that I write, including to choose the name they want me to use. But twice, patients have asked me, do you want me to write my response? Or they had things to say, enough comments that I thought maybe you want to write a response in addition to what I've written. And a couple of them did. And so that's also unique. The way that Beth's looking back, I think it's very unique to involve a patient in one's writing and to have their perspective as well. So two of my books include the perspective of patients. One of them, I finished the treatment. They came back. I had them come back, and I wanted to catch up with them. And they wanted to write a piece afterwards. And the other one, it was within an ongoing treatment. And I'm still seeing the person. And it becomes part of the work. It actually can enrich the work. They feel paid attention to. They feel it's a collaboration, that the work itself, the treatment and the writing become part of the collaborative mindset that we're in this together, and their perspective matters as much as mine. I think Beth could probably do this well with some of her patients as well. Something to think about for the future, Beth.
Well, that's very helpful. And the reason I asked is because I have my first patient I ever had when he was 11, and I was the first year of the child and adolescent program. He's now 58, and I'm still working with him.
No.
And I'll tell you why. Put your seatbelts on. He came to me because he found his mother, who had committed suicide, in his bedroom.
Oh, God.
His father, 2 years later, his father drank a can of Drano and killed himself. And the sister, the oldest sister who brought him to me at 11 years old, hung herself.
Oh my God.
The case is so insane, so dramatic, so overwhelming, and he's begging me. He took a hiatus. I haven't been working with him constantly, but the years that he wasn't seeing me, he really went off the deep end. And I have a real father-son kind of relationship with him. And he's begging me. He'd be happy if he knew I was bringing him up in this forum. And he's begging me to write up the case, and I'm thinking about it a lot. And I've sent him some things, and I love what you just said, Danielle, because it's so much a part of the collaboration. We're so engaged with each other. He knows a lot about me. I know a lot about him. So I've been his analyst, but I've also been, like a parent. And you. Beth, when you said that you have you want to be the idealized mother, I love being the idealized father, and now that I'm a grandfather, I can be both. So it's very nice. And I really appreciate that that answer. It really sort of gives me permission to go forward.
I'm giving you permission.
And I really appreciate it. I guess I needed a little permission.
Do it. It sounds like a fascinating case.
And it's a fascinating case. And
have him write something about
No,
it.
he wants to. He really wants to. I actually I teach young, and the other thing I wanted to express my appreciation for is I teach at a SUNY, and I teach, in a mental health counseling program. They're ages from 25 to 45, but they're very young and inexperienced, and they really when I talk about this, they really, and because I bring him up, obviously not mentioning his name, and it's very helpful in terms of helping beginning therapists. So when you both said that this is really helpful, I think Alan mentioned it too, that when we talk about these authentic experiences with young people, it's really liberating for them, because they're so caught up in they're being told by their supervisors, never reveal anything about yourself, and it's like a classical analytic approach. And I learned that for 20 years, and it took me 20 more years to unlearn a lot of that stuff. So I really appreciate both of you. Thanks for the permission.
And speaking of Alan, Alan's going to present a wonderful case also with a lot of drama and violence.
Yeah.
Is
There's
it
a
going to
lot
be
of
at a Meet the Author, Alan?
For the salon, I think.
At the salon, the upcoming salon.
Yeah. All right. Is there anyone I can't? Does anyone else have their hand up? I just wanted to ask something real quick about just remembering, like the thread, the idea that I had throughout reading it in the early stages, and then as it became a book, once it was complete, that this thread of having internalized the patients the way that you did and how they internalized you, and I wonder, like, about while you're writing it, how that change the way that you, if it changed, how you keep them with you now, like in your work with other patients, if writing the book somehow, just change the way you work or internalize patients, if so.
Yeah, I think it definitely did. When you sit with someone, you feel empathy for them. When you talk about a case in supervision, you come to understand them a little in a deeper way. And when you write about them, when you write dialogue back and forth, it's like you're answering questions from their perspective. And so you kind of get even more empathy and understanding for the depth of their conflicts, the the way they handle affect, how hard it is for them to say certain things and go certain places. Um, some of the things that words don't quite capture. And so you get a much better understanding for a lot of the implicit things that go on between you and the patient when you write about it. Um, and a fuller understanding of them. So I think it's been much more, been very helpful. And are there things I do differently? I hold back a lot less now.
Mm.
I hold back a lot less. I say things that I might not have said before. I ask questions I might not have asked before. I do it in a careful way. I try not to do it in an impulsive way. But now I'm more thinking better to overstep a little and have a rupture that we could talk about than to hold back and be too cautious.
Mm.
Right. Any of your patients that didn't make it to the book ask, hey, what about me? When they got when they-
One
or
one
can
in
I
par-
be
one in particular did. I said the second book.
I had a book where I had one chapter Mr. A, one chapter Mr. B, and Mr. B was very angry that he was B and not A. Marty.
Just a very quick aside. Beth, I wanted to tell you that I just bought the book.
Ah.
Thank you.
Thank you.
Thank you.
Anyone else?
I have a question for anybody who has read the book. I'm wondering, what was your favorite chapter?
Ah. Elizabeth?
I think her name was Jen in your book, sort of a chaotic shall we say, borderline presentation.
Mhm.
The struggles, I don't remember the specifics well enough, but the struggles you had with her just came all the patients with that, profile that I've ever worked with flooding back, and just
Uh-huh.
how difficult it can be to be in the room with someone like that. So that was my favorite. Very, very much validated my experience.
Okay, good. Good. That was the one that I said was the hardest one to write. So I'm glad you liked it.
And does that patient know of the chapter?
Mm-mm. She does not.
Somehow I'm not surprised.
Alan?
Um, you've changed my relationship to chicken parmesan forever. And yeah,
That's the title of a chapter, by the way.
chicken parm. Uh, they're just one or the other is describing their life, and it's a couple, and they say it's like
Your sex life.
chicken parm. It's very reliable, but it's not that exciting. I guess he's describing their sex life. But they come to appreciate the nuance and the fact that chicken parm done well is a hell of a good dish. So I love that. I love that metaphor.
I'm not sure how to raise my hand, so I apologize if I'm interrupting somebody else. But Beth, my reading group is reading this book together, and so we're about halfway through the book at this point. And so I can't comment on all the chapters, but I've found it fascinating, and I felt that what you wrote in the theory chapter was lovely, but when I finished it, I said to myself, I don't know if, like for myself, whether I really operate that way when I'm with patients. I'm not thinking in these terms so much. And so when you presented the material, I felt very close to the material. And I think Elizabeth commented on Bromberg in the several chapters that I've read. You've used his theory, and I felt that was very appropriate to that particular patient, that particular moment in time. So that made a lot of sense to me. I guess the other thought I just would throw it out is that at the very end of your book, you talk about things you would like people to take away from it. And I do think that you were very committed to all of your patients and you really cared about them. And I think that's sort of the basic. I mean, you can't really do very much with somebody if you don't really care about them, right? But I think that you always had to temper that with being realistic about it. I mean, knowing who they were and not just siding with the good part of them, like with Brian, that particular chapter. So anyway, I think it's a wonderful learning experience. I'm sure everybody's going to want to. I mean, it's fast and it's so easy to read. It's so absorbing, and sometimes we don't have case material to look at lately. I mean, it's been all so homogenized, and we don't feel a real person back in there. So this is really wonderful. Thank you.
Thank you so much. Thank you.
Any other questions? Still have about 10 minutes. Any thoughts or questions?
Larry, you usually ask a question. Not to put you on the spot.
Well, as someone who's a follower of Lacan, it's a very different way of thinking. It's a very different way of working. Lacanians, but I'm very interested now in self-psychology and Laplanche. So I'm moving more in your direction, Beth. And thank you so much for a very courageous and exciting presentation. I even want to read the book, Not Being a Relational Analyst.
Thank you.
Thank you. When I'm with patients, I'm focused on what is their conscious desire and what might be their unconscious desire. What is driving them? What might the transference be? And what do they substitute for the void that they find themselves facing? How do they fill up that void? How do they fill up that emptiness? I hate to say it's a one-person psychology, but the Lacanians talk about not projecting. You talk about authenticity, and you talk about honesty. Well, just what is authenticity, and just what is honesty, and is it in any way projecting who you are onto that patient, who for Lacan is radically different from you, the analyst, and how to respect, honor, and be open to that radical difference. They are not, my patient is not me. I'm 80 at this point, and I'm still in practice, much smaller practice. But I've been just fascinated with Lacan, and I wonder if you might find a way to speak to what I'm concerned about insofar as projecting who I am onto this patient, my concerns. I think it's great asking questions and opening up areas that they may not want to even acknowledge. But I think the sharing who I am as a person easily gets in the way of who they are, what they need to say. And that's why we use the couch. And I have many people in my practice who lie on the couch and put the telephone. I don't see anyone in person, but they put the telephone behind them. And they feel much freer to get in touch with things they might not say were we face to face. So please, Beth.
Well, I think we're talking about very different things. One approach can't offer everything. So I think the freedom to say that those things that are so difficult to think, never mind say, and to let your mind roam freely when you're sitting across the room looking at somebody is very different. And perhaps the method that you're talking about is preferable for that. I know when I'm with someone, I don't share that much of I mean, look, I wear a wedding ring. There are pictures of my dogs. They're not pictures of my kids in the office, but they're pictures of dogs past and present. But it's not that I share so much of myself. And I don't think I project myself onto my patients. I don't think I see myself in them. I'm asking myself, who are they at this moment? A lot of times I ask myself, how old are they at this moment? Am I looking at the 8-year-old Brian, or am I looking at the 30-year-old Brian? Am I looking at the 16-year-old Brian? And what does he need from me? And that's kind of what touches on, the who are they now is more the self state. Is it the child self state? That's more the Bromberg kind of the addict self state. Which self state am I interfacing with? And what do they need from me? More like Stephen Stern's the needed relationship. Are we engaged in a repeated relationship? Is this the transference? Is this their usual dynamic being replayed? Or more often, am I feeling a pull for something? Am I feeling a pull for them to need me to be something for them? Their self-object needs, for lack of a better term. Do they need me to offer them some guidance or some emotional protection? Do they need me clearly to understand them and understand exactly the nuances of what they're experiencing? So that's more kind of where I go with it. I don't feel like there's a lot of projecting going on.
And if you're not who they need you to be, can you sit with the anxiety and the void and what they're going through at that moment, which is probably what they go through alone repeatedly?
Yeah, I'm going to say that their needs are very often far greater than what I'm going to offer them, even if I correctly understand it. So I can not only sit with it, but find words for it so that we both understand that this is 45 minutes in a very long week. And maybe begin to talk about how they can find what they're looking for in other areas as well, and what gets in their way. I say to this one particular person who's not in the book, if only other people saw the guy who's sitting here with me, because they don't. I get to see a certain version of him sometimes. So I think that that's kind of helpful.
Yeah. One of the most fascinating things Lacan says is that the only resistance is the resistance of the analyst. And I know you agree with that.
I do.
Yeah, because you came too with this child that could not speak. Yeah.
You know, she didn't speak, and it was terribly painful for her and for me, but
Mm.
she showed me what her internal world was like. And when I stopped trying to insist that she use words and just sat with her, I was feeling my discomfort. I was feeling her discomfort. And I was getting a picture of this bleak and lonely and dark inner world
Mm.
that really, even if she had talked her little head off, would never have conveyed the way sitting there silently did.
Right. One of the Lacanians I worked with for years said one of the only reasons the analyst speaks is from out of his or her anxiety. And so much is allowing the silence so that the other's anguish can emerge. And we can really begin looking at something that is beyond words.
I think we have to be careful, though, not to induce that anguish by
Okay,
not speaking and leaving them abandoned. So there's a
absolutely.
middle ground.
I'm with you for sure. Yeah,
Okay,
thank you.
Thank you.
thanks.
Well, I just want to thank you both, Beth and Danielle, for this wonderful presentation. This was really great, and for everyone's comments and questions. Thank you so much, and to ASPP and Amira. So I'm going to turn it over to Elizabeth, who still has some information for you all. Thank you so much for coming.
Yeah, thank you. And I echo Dustin and just thanking Beth and Danielle and our whole ASPP team, Rockafet, Danielle, Meg, who am I missing, and Leah. And if you guys want CE credits, please make sure you fill out and send in the evaluation within 3 days after you receive it. We will email the evaluation after we tally how many minutes everyone was in here, and everyone who qualifies will get the email with the evaluation. And since Alan mentioned it, there will be an ASPP in-person salon with Alan Weiss presenting his case and paper in person in Garden City on December 7th. So look for the flyer advertising that. We tend to have a really nice afternoon with someone presenting, a nice discussion, and some food and drink. So look for that flyer. And thanks to everyone for joining us and for all the lively conversation. And I hope everyone enjoys their evening and the work week to come.
Thanks so much.